All right, so drip management. You got a leak. We got to then figure out what is going on with our drips, right? So how do I avoid using my crochet skills? All this stuff is manipulated there into a jumbled mess. You want to be somewhat organized, and we have to be organized on the top half here. Get things labeled, make sure tubings are changed appropriately, make sure everything's programmed appropriately, and make sure things are plugged into. That's probably a good idea, so that we are getting a, thank you, so we're getting an adequate management of our drips. And of course, documentation. Is it the right concentration? Is it the right medication? So we got to make sure all those things are good on handoff and every time we spike a new bag, for instance. All right, so IV choice. So what IV access do we have? So central lines should be used for vesicants. Do I need a central line for propofol infusion? No. Do I need it for norepinephrine infusion? Yes, right? So this is a mechanic who came to our hospital, got a nice big thumb IV placed right here, right? Thumb IV, what's a big thumb IV? That's like a 22 on a good day, right? So you had a 22 gauge IV placed to the thumb, put Levophed through it, looked pretty bad, worse, and then it came off. Right? It wasn't like a bed bath. We had amputated it, right? So we had to, that's a Levophed infusion, which is a vesicant. We know that Levophed literally eats through this internal layer of the vessel. It's called the vasovasorum. So and when you get higher up into a central vessel, it's much, much thicker. It's much more difficult for Levophed to eat through it, right? So this wasn't like an IV that infiltrated. It was an IV that was extravasated because it literally eat its way from the inside out. Right, so the vasovasorum in the thumb is much, much smaller than it would be like in a midline, for instance. And a midline, is that good for pressors? Maybe in a pinch for the first 8 hours, 12 hours, because we do place it under ultrasound. It's probably a vein that's 4 millimeters in diameter at least. But again, this is just temporary. So Levophed is not coming down, right? It's the Levophed's going 10 mics, 14 mics, 20 mics, 30 mics. That's time to get a central access, right? But if we're like Levophed like 8 mics and it's 4 mics, and then so I can get them off the next 4 hours, then yeah, then a midline would be appropriate, or an ultrasound guided IV up in the upper arm, which has a thicker vasovasorum or a thicker inner lining of the vessel. Okay, so what else? So arterial lines are usually needed for pressors because if we're especially on multiple pressors, so we can titrate accurately. We can get frequent ABGs and labs. You can recognize changes right away. Peripheral access again is a temporary measure, right? If pressures are coming down, then we can then think about keeping it around. But otherwise, if it's in there, it's like it's been low for like 3 days, like we probably need central line. Okay, and then vesicants. So vesicants usually are hyperosmolar solutions. Is Levophed hyperosmolar? No, but it's literally the pH is so damaging to the lining, it will eat its way through. Well, other things eat the way through are things that have a really, really high osmolarity. So they're really, really high, and then the water is going to tear from the tissues into the bloodstream. It's going to want to go for sure there, and it's going to start eating away at the vessels, causing osmotic damage to that vessel lining, and now the medication can extravasate and cause damage, right? So hyperosmolar solutions are ones that are going to cause a damage to the vessel lining, and we then need a central line for that, right? So what are some examples? Something like that's greater than 3%. It's been a fight for about 50 years for, they say, oh, they got 3%, you got to get a central line. That's absolutely been disproven. That's not a thing, right? So 3% is usually, 1,000 is probably about a little closer to 900. When you're greater than 900 osmolarity, that's where you consider a change from a peripheral line to a central line. So greater than 900, and if you look at, say, some kind of drug guide, it might tell you, there's a quick list, right? So you got mannitol infusion, you got a 5%, so greater than 3%. Saline definitely needs to have a central line. You got a sodium bicarb, right? No one bats an eye if you give a sodium bicarb IV push, right? No one bats an eye if you give D50 IV push via peripheral line. Like, cool, go for it. How was it? Was it cool? It was really hard, but I got it in, right? But it can cause a literal tearing of the vessels, right? If you look at D20, that's not even D50, right? It's D25%. That has an osmolarity about 1,000, 1,100, whereas a bicarb has a osmolarity of 2,000, right? So you have a bicarb push via peripheral line, that can cause a lot of damage to that vessel lining. Okay, so greater than 900 milliosmoles, or you got greater than 20% dextrose, that is where you need to have a central line in place, right? Like TPN, for instance, has a dextrose percentage of what? D20, right? So D20. So anything less than D20, it can be peripheral, right? If you're more than D20, like an IV push, D25, or you're on TPN infusion continuously, which is D20, that's going to tear through these vessel linings and going to rupture them, right? So we want to make sure that we are getting switched over to such a line as soon as possible when we're giving frequent pushes of bicarb, frequent dextrose pushes, and of course when we have a dextrose infusion that's more than D20. All right, so how do you manage extravasation once a medication is leaked out into the interstitial spaces, right? So of course you want to mark it, you want to make sure it's not spreading, but we can give a reversal agent. So we got to find out what medication it was, because certain medications have reversals, right? Certain medications you have to give like a hot pack or cold pack. Usually a warm pack will work, right? But in the meantime, it usually comes from like the chemotherapy world where they have a lot of extravasation, a lot of toxic meds. But for our purposes, when we talk about epinephrine and dopamine and norepinephrine, neosynephrine, we're going to give something that's going to vasodilate. So you can throw a little nitro patch on there, a little topical nitro to help dilate the area. But really, we give little alpha 2. What are they going to be? Agonists, right? They're going to bind there and they're going to vasodilate that area right there, right? That's called phentolamine. Are they blocker? They're going to be, there are alpha 2 agonists that work over here, but we're looking at blocking the actual norepinephrine or the epinephrine or the dopamine or the phenylephrine that binds that alpha 1 receptor. We're going to displace it with our phentolamine, right? So it's an alpha 1 blocker. So alpha blocker, alpha 1. An alpha 2 agonist would work, but alpha 1 blocker is what's recommended. That's our phentolamine, or Regitine is the brand name, and that's given sub-Q, right? So you just give it in a clockwise manner. You draw about 5 to 8 cc's, and you just inject like a pin cushion. All right, it's called a pin cushion technique. All right. So when you have a extravasation, you have to slap the patient. And what does that mean? You're going to don't slap the patient, but you're going to stop the infusion of the vasopressor, and you're going to leave the IV in place, because the IV can then be aspirated. You can aspirate the medication. You can even give the Regitine into that area if need be, all right? Or any other antidote if it's another fancy medication. And then P is going to provide the antidote. That's going to be our phentolamine and pressors when we have it given pressors. Again, 8 to 10 times to the affected area, and then you can remove the IV. And of course, you want photo documentation to make sure it's not getting worse. Okay, so you see phentolamine here is an alpha blocker, whereas our dopamine and our other guys, those are all alpha 1 agonists. They are going to vasoconstrict. We want to vasodilate and dilate out the area so the medication can get reabsorbed, so to just stay there in the tissue and start breaking it down more and becoming more and more necrotic. We want it to be reabsorbed in the bloodstream as best as possible. All right, so IV compatibility. So we used to have these charts in our med rooms. So you can then say, is this medication compatible? And you have to go over, oh, there it is, and I'm going to that one right there, and yep, it's compatible, right? And then you have to do that for all your other 6 other drips. It's like, well, this one, that one, but then that one wasn't that one, and then that one, and you're like, it's like a Sudoku at that point, right? Have I used the number 9 yet? All right, so that's going to be it's a little laborious. So we have a little compatibility checker, right? The micromedics, we still use micromedics, yes? Those guys have used it, right? They wanted to switch to something else. I don't think they've done it yet. All right, so you just click on micromedics, click link right there in Cerner, and that's going to then bring to the IV compatibility tab, and you're going to then put in your medications. You can put in all your medications right there. So I put in cisatracurium, fentanyl, propofol, Levophed, and I put in, those are the 3-4 drips I got infusing, right? So then it's going to tell you right away what's compatible, what's not. So cisatracurium and propofol are not compatible, incompatible. Right, so I'm not going to give those on the same line. Everything else can go on the same port if I wanted to. Right, every single thing can go one port. So I need definitely 2 ports, one for my cisatracurium and one for all my other stuff. Or I can mix and match, and I can try to figure out what would work best. Usually, I like to have my pressors in one place and my sedation somewhere else. But in this case, I couldn't put my propofol and my paralytics together. Okay, so you want to check this so we're not doing like any experiments in the room, right? We don't want like crystals to form and things to change color. So to make sure that we are identifying what is compatible, what's not. And sometimes it'll say variable, I believe it says, what says variable or use caution or something. And these are all clickable links. And you can click the link and it will tell you exactly why or exactly which products are incompatible. So like Abbott Manufacturing versus, I don't know, the different manufacturers. What is it? Big Pharma, what's the other name for the one that does Viagra? And the COVID vaccine, AstraZeneca, or with different pharmacy manufacturers and compounding places, based on the concentration, it might not be compatible, or based on whatever agent they use at their facility might not be compatible. So you can see this one's incompatible, but if I look at the next one, it might be compatible. So as long as I'm using that concentration, and from this, like there's AstraZeneca right there, and there's, was it Garnitia Sicon, right? So that one obviously is not compatible, right? All right, so IV tubing and labeling it and programming the pumps. So these are all things that are standard practice, need to be done, is on your IV titration competency. You need to label your tubing, right? Whenever you have 2 or more things infusing. If one thing infusing, one pump there, I know what it is. I can look, that's what's infusing, right? But if I have more than 2 things going to the patient, I need to have a labeling system happening. So I got 4 things going to this patient right now. I need to label it, right? So I got a TKO or main IV fluids here. I got my Levofed right there, right? And then I have, let's all go on the same one, right? And then I have a white thing. Sometimes we don't label the white thing because we know what the white thing is. What's the white thing? Propofol, right? So I don't really need a label for that. I know that's propofol. Unless it's lipids, right? And they're getting TPN, then that will require some, because you could get both of them, but usually the dietary and nutrition services is going to modify lipids. So, hey, you don't need lipids because you're on this much propofol, or you're on this much propofol. Let's reduce your lipids to half a bag per day instead of the full bag. Okay, so labeling tubing, again, allows easy identification during ACLS. Patient starts getting a low heart rate, starts going to PEA. You're like, shoot, which medication, which one can I use? Not the white one, probably not that one. So this situation might be good, but it might be a Levofed there, right? And someone might have put their main IV over here. And it's like, well, did you check all your Zosyn, your vancomycin, if that's also compatible with propofol? I don't know if you did, right? So usually we have our main IV on a single lumen by itself. All right, there's different options out there to label them. We can have our whole little row of things. Usually we just have our plain white labels. This thing fill out a favor, or actually fill out of batteries and fill out a contract. We've been trying to get it ongoing for about three years or so, where it'll print the label for you. You just scan the bag and it prints it for you, and it'll tell you exactly when to change it and all the different things. You can program it for whatever you want. So we can fire that back up if we want to. We just got to pay the bill. So he gave me a sample. It's like, oh yeah, you owe $1,000. It's like, okay, cool, sure, right? Other than that, we just get a plain old white label from the printer and we label it with what is infusing, and then of course you need to label for when that tubing expires, right? Because the tubing expires how often? When does the tubing expire? Usually 72 hours is default, right? CDC says 96, but we say 72, so it gets changed within that 4 days, right? And then the other piece with that is the little exception to that, right? The exception is what? Yeah, so lipids, right? So lipids are which? 24, 12, or 4? They are 12. What's changed every 24? Good, TPN, right? So dextrose containing solutions greater than D10, right? Greater than D10, like you're getting PPN, peripheral parenteral nutrition, then you would have to change the tubing every 24 hours, right? Every 4 hours. What gets changed every 4 hours? Those are your blood products, right? Or usually after 2 units, whatever comes first. And then as far as the bags themselves, how good are the bags for? 24 hours. 24 hours no matter what, except for, little exception. Which one? It's the same as these ones. It's propofol, you got to change the bottle every 12 hours, right? So if it's 12 hours, the propofol is not good, you got to change the tubing and the bottle, right? Same thing with blood products, right? Blood products is after 2 units or after 4 hours, whatever comes first. All right, then program the pumps. Please don't roller clamp it. And the reason I put that is because someone has, all right? So please don't you don't just roller clamp the drips. All right, patient comes up from the ED and they're roller clamp Levofed. It's like, yeah, it's about 3 drops from, it's like, no, that's not good. We need to have, so we ran out of pumps. So we got to find pumps. We got to make sure we're giving them pumps in the first place. That's why we have a pump process. So we can start it properly in the areas outside the ICU. And you want to make sure that we have every drip needs to be in a channel. It is okay to use fluids or crystalloids in emergency. You can't give it a pressure bag or drip it in, but best practice is to program it into the pump, right? Never is okay for a drip of any point, at any point. Okay, it takes seconds to program it, even though the computer needs to fire up and you need to find it, and the scanner doesn't work, you have to go get another scanner. You can still program it manually. That's still allowed. You can still find it from the menu, and it's still, select Levofed, select the right concentration, and start it, and then get your stuff in the channel so it can be infused rapidly. And then you can take credit for it later in iAware and in iView, right, and Cerner. Okay, keep pumps on the same side, right, so that we're not avoiding tugging on the line, right, so we have we're not going to displace our tubing. All right, give them a report on your drips. So give the dosage, not the rate. I say Levophed going at 12 mLs an hour. That's not okay, because you can have Levophed that's double concentrated. That's 16 mics at 250 versus 8 mics at 250. Those can mean two different things, right? 12 mLs an hour could be a lot or little. So we want to make sure we're always giving the dosage, right? How many mics is it? How many units is it? How many kilos is it? Or what is the dose per? And of course, the kilos part we talked about at the beginning about your titrations, whether it's, the dosing weight needs to be changed or not. So if it doesn't match the order and such. Okay, so if it's like 4 and 250 versus 8 and 250, 4 mics per minute of Levophed, that could be either 15 or 7.5 mLs an hour. But 4 mics is 4 mics is 4 mics, whether it's whatever concentration Levophed you may have hung, right? So do note excessive volume rates. So if you're giving like 199 mLs per hour of phenylephrine likes to be a large volume bolus. You can double concentrate it or quadruple concentrate it, but we want to be aware of that we do get a lot of fluid creep in the ICU, right? Where a lot of different things are giving fluids to the patient, and if we can avoid it, we can avoid it, right? So we can double concentrate or quadruple concentrate our drips. But if that happens, we have to change the pump for sure, right? Make sure the pump is accurate, but what else do you need to change? The tubing, right? So all the tubing distal to it is going to be whatever the previous concentration was, 20 cc's of it, right? And if you double concentrate it, is it going to provide a faster rate or slower rate? It's going to provide a slower rate initially, right? So if 4 cc's has, like, let's say 10 mics Levophed, right? And you double concentrate it, that means you only need to have 2 cc's. So you're going to be infusing less than that first 20 cc's. But after that, then you're going to start overdosing the patient, right? So to make sure that we are, if we didn't program it correctly. All right, so always have a new bag ready to go, especially your pressors, right? Sometimes I mentioned like fentanyl might be frowned upon because they're tracking this downstairs to make sure if someone pulls fentanyl that it's being given within 10 to 15 minutes. All right, but on handoff, you want to be, and with new bags, you want to make sure we're doing an independent double check, right? We are allowed to change the Levophed and we're allowed to change the fentanyl because we know how to titrate it, right? But if we're hanging a new bag, your job is to find another nurse so they can independently double check it and make sure that bag has not changed concentration, right? And that the rate matches the rate in the computer, which means your weights are correct as well. Okay, so we're co-signing in the chart, and we are making sure that they're identifying which is that the medication is the correct dose or correct concentration, and that we have the right medication infusing. Okay, so all drips need a RN witness. Which drips need a RN witness for every single titration?
Insulin.
Yeah, so the exception is insulin and what else? Heparin. And heparin, right? So those you need a RN witness for every single titration. Otherwise, it's just for the bag change and on handoff. So on handoff right here at 7:30, you're going to be checking all the drips, make sure they all line up, and we should see 2 names for each person, right? Sorry, for 2 names for each drip. All right, so we're right-clicking, adding comments, and that way that is an independent double check. Okay, so wasted narcotics, you used to be able to do it through iAware or iView, which made the most sense, but they now do it through the Pyxis, right? So you go to the Pyxis, you find the med, enter the volume you're wasting, and you get a witness. And that could be easily fumbled from the patient's room to the Pyxis. Like, oh yeah, there's 25 cc's, I promise. Whereas you bring in the room, they can say, yeah, there's 25 cc's right there. I see it. You're perfectly right. All right, but what needs to be wasted? That's a narcotic of some sort, right? Technically, this is where we're going to use the DEA definition, right? A Schedule 2 substance or Schedule 3 substance. Hopefully, we're not giving cocaine or heroin to a patient, but if we're giving, again, not cocaine or meth, but we're giving something that is like Demerol. We don't really give Demerol, but something like fentanyl needs to be witnessed, right? Propofol is narcotic, but it's not a Schedule 2 or 3 drug, so you don't need a witness for it technically if you're wasting. Right, Presidex is not a narcotic, so you don't need a witness for Presidex when you are wasting. When you're doing a bag, you start a bag for a patient, you do want a witness to make sure it's the right dose. Right, that's the difference. All right, so controlled substance, anything that is nefarious, that someone is going to want in the streets. Right, nobody wants propofol except for the king of pop. All right, so then backup. So that was the old method in case our Pyxis goes down, I guess. So we won't discuss those just yet, all right? But anything that's Schedule 2, 3, or 4, those usually need to have a witness in the Pyxis. And this is tracked and trended to make sure that we are, there's not missing narcotics somewhere in the ICU or PACU or whatnot. All right, documentation of drips, right? So where do you document your drips? So this is an eye view or eye aware. These are good ways to capture the drips in real time, and you can then go ahead and populate it in, right? And the piece with this is that you have to have assessment data at the same time as your titration, right? So if I have a, let's say I got dopamine at 26 right here, I should have a blood pressure at the exact same time, right? It can't be 2 minutes later, it can't be 1 minute later. It has to be at the same time of titration. So I went from 24 to 26 mics. So I went to 26 mics, I then titrated that because my blood pressure was MAP 55. Why'd you do that? Well, the order said so. It says to achieve a MAP of what? Greater than or equal to 65, right? The next one up actually, right? So MAP of greater than 65. So that's my goal for dopamine, and that's how I titrated it. So that's an appropriate documentation. And where do I do that? I have two options, iView or iAware. They will get me my information into the system that way, right? And when do you do this? Again, at the time of titration, right? You chart the blood pressure or you chart the heart rate. What's the medication you might titrate to heart rate? Amiodarone is usually not titrated, it's going to be just adjusted after 6 hours, then at the 18-hour mark. But diltiazem might be something, right? The heart rate is 90, and it says titrate to a heart rate greater than 110, for instance, or reduce the rate if your heart rate is less than 110. So we chart the heart rate at the same point, right? RAS scale, what's the RAS scale titrated? What's the medication might be titrated to RAS scale? Yeah, any sedatives, right? Same thing with BIS, right? And then pain, that'd be your fentanyl infusions or your Dilaudid infusions. So you're going to titrate the pain score at the same time you titrated the fentanyl. And you're going to say yes and nod your head right now, but it happens a lot where we don't do that. Where you're going to say, I tried, CPOT was 5, and then then you titrate it off by a minute, right? So that doesn't meet criteria by the Joint Commission, right? The Joint Commission did I stutter? I said at the time of titration, not 1 minute after, not 5 minutes after, at the time of titration. Okay. So each assessment, we want to chart our stuff, right? Well, every 4 hours, we do a routine assessment of our patient, full head to toe. You should also write down what is infusing my patient. So at 8 o'clock, I got 4 mics of Levophed, I got 2 mics of fentanyl, 40 mics of propofol. That's kind of your starting point. And then noon comes around, you can still write down what you have infusing. A little snapshot of what's going on. It's your full assessment, right? And if you're still at 2 mics of fentanyl, like, oh shoot, my CPOT's been 0 all day. Now it kind of prompts you to go ahead and come down on the fentanyl, for instance. Right, so that's the idea behind doing it every 4 hours. We have something titrated every 4 hours. And of course, you're titrating whenever we titrate, we're going to document as well. The other time you're going to see titration or see documentation for sure is on report or handoff. If you're changing nurses halfway through the shift, census might be low, or you got, it's like you're the only balloon pump trained nurse in the hospital, and then you have to then give up your assignment to someone else at 1 o'clock, then you have to then sign off with someone else, right? So whenever it switches RNs, you need to have a sign off done, okay? So you want to make sure you're recording the objective measurements. So that's these objective things that we're recording at time of titration. All right, so documenting and checking orders. Remember, you want to check your orders because sometimes it will change. Changes every Thursday without notice. I tried to ask corporate, can you please let us know? Just a quick email. There's these things called emails nowadays. I think it's new. It's kind of like it came out with the QR code, right? Just go ahead and send me a little email when you're going to say Levophed is going to be 0.5 and not 2 mics every 5 minutes, right? Or they'll say 2 mics every 10 minutes. Like, well, what made you decide that? Was there a committee? I wasn't invited. Anyways, so you want to make sure that you are checking the orders. So on handoff, you're checking not only are the right medications infusing, but it kind of gives you an idea, okay, we're doing Levophed by 2 mics, we're doing propofol by 5 mics. And you'll learn what the standard is, right? Little badge buddies we gave you, those are the standards, right? If it's anything besides the standards, you should kind of like make a little quick note on your brain. Okay, so document vitals with pressors, that's your stuff at the time of titration, right? So we're documenting, we got what was this, norepinephrine. We went from 5.5 to 6 mics, and this says by 0.5s, so that's cool. Because I'm used to it being every 2 mics, so that's why I would pause, whoa, 5.5 to 6, why'd you do that? Well, the order says by 0.5s. But what's wrong here? 801 is 64 MAP, and it says titrate to a MAP of 64 or 65. That's good, that works, but that's not at the time of titration. So that falls out. So the Joint Commission would say that as a failure. All right, so you're a failure today. All right, so yeah, so that you want to make sure you're charting at the same time as your titration, right? You just got to line it up. All you got to do is titrate it, write it again right there. But ideally, you want to make sure it's at the same time as your vital sign or your parameter that your drip is for. Okay, verify the drips are correctly titrated and make sure the scales match with what you think you are. Hover over the drip, like this every 5 minutes. This is every 10 minutes, right? Propofol every 10. So make sure that you're not on some weird scale. You're not doing what you think you should be doing. Make sure you're looking at the orders, they all line up, right? So is this propofol appropriate? It says titrate by 5 every 10 minutes. So propofol says what? So we're going at 40 mics right here, right? And we go 7:30, 8 o'clock, 8:40. I think there's another slide here. There it is. That makes more sense. All right. So that's the fentanyl, but propofol should be done by every 10 minutes, right? So that RAS was -5 on the previous thing, so that's way too deep, right? The RAS score said what, 0, -1, I believe. So you want to make sure that we are titrating to what's ordered. And this fentanyl, for instance, so this fentanyl says we're going to be at what? We're at 3 mics right now. It says titrate to a CPOT of 3 or less, and my CPOT is 0, and that's 740. Is 920, right? That's 1620, and there's been no titrations throughout the whole day of my fentanyl, right? So that's too much fentanyl. So I should be coming down on the fentanyl in that situation, right? If you have a really busy morning, that happens. You got an EGD and a trach and I got to take a patient to CT and an MRI, and you finally get back at noon, you reassess, oh shoot, maybe I should come down on the fentanyl a little bit on my other patient, right? So you could come down. So that's why every 4 hours is kind of gets you back on track at least. Okay, and then independent double check. So independent double check is everything needs independent double check, but titrations, we are trained to do titrations except for insulin and heparin, right? And argatroban's are alternative to heparin. These guys, every titration is witnessed, whereas before, independent double checks are done with every bag change, right? Every change in concentration would be a reason to get another RN to witness, right? And again, it's an independent double check. So what does that mean? That means they come in and they assess the situation. Hey, can you witness my insulin? And they come in, they look at it, and they look at everything, and they then sign it off, right? That's what independent double check is. It's not saying, hey, my insulin's at 2 units. It's at 2 units. You're gonna sign 2 units, right? 2 units, right? So that's confirmation bias, right? This is why horoscopes come out in the morning before your day starts, right? They came at the end of the day. That didn't happen, right? But then horoscopes have confirmation bias, where they capture about 80% of the audience, and it kind of makes sense, right? So we want to make sure that we're not skewing someone's perception of what's going on. All right, so I got levofed at 4 and 250, and it's going at 4 mics, and they come in there, and it's not those things, right? And we mentioned what can go to tele. It's usually hemodynamically stable patients. We know diltiazem go to tele as long as we change the order to say no titration, just a fixed rate, right? But again, we have to look at, is the patient hemodynamically stable? So heart rate of 28 and BP that's really high, not great. Heart rate that's more than 130 and BP to the borderline, that's not a great patient to go to tele, right? So non-titratable fixed doses, amio, diltiazem, usually when your heart rate is less than 130 and they're not symptomatic, they're not like diaphoretic and breathing really hard, then that's probably a patient that's cool to go to tele. Okay, with fixed doses. Inotropes can go to tele, and how I know this, we have a policy. So the policy tells us cardiac tele, what's good for them, all right? They can get heparin drips, they can get dobutamine, they can get dopamine as long as they are fixed dose. Okay, they can get diltiazem as well. They can get Ativan IV push. We have a whole little formula that tells you what they can and can't get, and there's a whole formula that tells you what requires independent double check and what doesn't. But basically everything does. You just got to know what doesn't. Would be a better strategy. Okay, so GI, Protonix, octreotide, those can be fixed rates on tele. All right, that's it for IV titrations.